Dr. Fauzia Riaz is a medical oncologist specializing in breast cancer at Stanford University. She is also currently a clinical assistant professor in the Department of Medicine at Stanford University School of Medicine. Dr. Riaz is an avid researcher and completed formal research training during her fellowship at Yale Cancer Center through their Advanced Health Sciences Research Program, culminating in the completion of a Master of Health Sciences. As faculty, she is an active member of the Stanford Breast Oncology Clinical Research Group and currently serves as the Stanford Principal Investigator and Sub-Investigator for several ongoing breast cancer clinical trials, with a research focus on novel therapeutics and approaches to the treatment of breast cancer. Ladies and gentlemen, please welcome Dr. Fauzia Riaz.
Great. Good morning, or good afternoon, I guess I should say. It is truly an honor to be invited to speak, and truly a pleasure to be here to chat with you guys about early stage of breast cancer. Okay, great. So today I really want to focus on giving an overview of early stage breast cancer, discuss diagnostic imaging and staging, and to review some key trials that impact our decisions. No, let's see next. But before I go into all of that, I wanted to step back and go over what the anatomy of the breast looks like, because it's going to be so relevant when we're talking about things like staging and diagnosis and pathology. And so ultimately, if you slice the breast in half, we're able to see that the breast is composed of and ducts. Lobules produce milk, ducts transport that milk to the nipple, and most breast cancers are actually going to arise from either the ducts or the lobules. Rarely we'll see breast cancer arising from connective tissue surrounding these structures, but most, over 90% of breast cancers are going to be coming from either the ducts or the lobules. If you look at least what appears to be my left, we can see that there are lymph nodes surrounding the breast. And oftentimes these lymph nodes are assessed when we are staging breast cancer and assessing for spread of breast cancer. This is one of the first places that breast cancer will often spread. And so how do we look for breast cancer? And mammography is sort of that first step. And we're finding a lot more breast cancer before it's something that's even palpable. So there's different types of mammography. There's screening mammograms, there's diagnostic mammograms. And so just some key differences between the two types. A screening mammogram is, ordered typically for someone who does not have any abnormal findings or any atypical findings on their physical examination. There's no breast-related complaints, and it tends to be a standard two views of the breast. On the contrary, a diagnostic mammogram is when we're actually looking for something. Someone is coming into clinic, they're symptomatic, there's a mass that they feel, there's some thickening of the skin, there's changes in how the skin looks. There's actually a radiologist who's on site who then reviews and tailors that study to make sure we have the most appropriate and adequate imaging to understand what is going on. It does require a clear clinical history and location or area of concern. It oftentimes will include additional views, compression views, and ultrasound as needed to further characterize the abnormality. And oftentimes, we get these reports that tell us what the mammogram results are. It's important to understand that there's actually a very standardized way that radiologists report out mammogram results. And so, when looking at a report, you'll often see the word BIRADS followed by a number. And each one of these numbers actually is has a very clear, very distinct definition. So BIRADS 0, for example, insufficient data, we need further views. BIRADS 1, it's negative, there's really nothing to comment on. BIRADS 2, there's a benign finding, maybe a cyst and a little adenoma, but really very benign, nothing concerning. BIRADS 3, something that's probably benign, and in those cases, we know we want to go ahead and get another repeat mammogram within a short interval. Sometimes that interval is 3 months, usually it's closer to 6 months. A BIRADS 4 is something that is concerning or suspicious for malignancy. And so in those situations, there's usually consider biopsy or maybe repeat imaging sooner rather than later. And actually, it's not on this slide, but we often can break down BIRADS 4 into BIRADS 4A, B, or C, A being low suspicion for malignancy, B being intermediate, and C being high suspicion for malignancy. A BIRADS 5 is something that's probably malignancy and needs a biopsy as soon as possible, and a BIRADS 6 is something that is a biopsy-proven malignancy. There's lots of risk factors for breast cancer, and this is just a few of them. And as you may notice, there's lots that are on there that are not modifiable, things like age, family history, genetics, age of when someone starts their period. But there are some modifiable risk factors, things like alcohol intake, exercise, BMI. Those are things that can that you, if you're a patient or if you take care of patients who have breast cancer, can really focus on to help reduce that risk of breast cancer. And so once breast cancer is diagnosed, I think one of the first questions that I'm often asked is, well, what's the stage of my cancer? And so breast cancer, we use a staging system called the TNM staging system. And in each of those letters actually represents a different component of the stage. So the size of the tumor, T, how large is the cancer, has it grown into nearby structures? And here we can see that there is a cancer. If we look in the picture on the right, there's a cancer. You can see maybe it's invading into some of that muscle. And so those are things that we look at when we are determining the stage. You may remember that I said lymph nodes are also an important part of the stage, an important structure surrounding the breast, and it's oftentimes one of the first places that we see breast cancer spreading. And so has the cancer spread to nearby lymph nodes? And if so, how many? What location? And finally, the M in TNM stands for metastasis. And so is there evidence of breast cancer that's spread outside of the breast? Is there concern that's spread to the lungs, the liver, the brain, the bone, etc.? And so we take into account all of these components to determine the stage of breast cancer. But unfortunately, it's not that simple. There's also a couple other features of staging. So there's something called pathologic staging. It's sometimes called surgical stage. So at the time of surgery, how big is the tumor? How many lymph nodes are truly involved? There's also clinical staging, which is based off of imaging, mammogram, ultrasound, sometimes MRI, the exam. How big does the tumor feel? Does your doctor, your provider feel any lymph nodes? And so that's actually called clinical staging. And each one of those have their role in the management of breast cancer. And finally, we do have a third layer of staging. There's something called anatomic staging versus prognostic staging. And so anatomic is truly focused on the size of the tumor, the lymph nodes involved, and whether or not there's any concern or evidence of distant disease. Whereas prognostic staging takes not only into account those factors, but also the grade of the tumor, the receptor status, genomic assays, all things that I will go into. And so clearly, the staging of breast cancer is very complicated, and oftentimes, depending on what type of staging your doctor or your surgeon uses, there may be some variation in what you hear. But ultimately, what we focus on when we're thinking about the treatment of breast cancer is the anatomic stage. And why is stage important? Well, this is an old slide. It comes from a journal article from 2006. So our survival rates actually look much better now. But in fact, the stage affects survival. And so early detection improves survival, which is why getting surveillance mammograms or screening mammograms, is incredibly important. And I think it's also incredibly important to remember that breast cancer is not one disease. In fact, it is an incredibly heterogeneous disease. And if we look here, the distribution of female breast cancer subtype is actually, as you can see, there's a wide variety. And this is something that is constantly evolving, constantly changing as we learn more about breast cancer. But today I'm going to really focus on three major categories of early stage breast cancer: the estrogen receptor positive, progesterone receptor positive breast cancers, the HER2 positive breast cancers, and the triple negative breast cancer. So just to define each one of those really quickly, so hormone receptor positive breast cancer, as you can see here, inside the cell, you see almost like this horseshoe shape and this V-shape diagram that I have. Those represent the receptors. If you imagine them almost as gloves on the cancer cell that are using the body's naturally produced estrogen and progesterone as a food supply. And so that is what we call estrogen and progesterone receptor, or hormone receptor positive breast cancer. HER2 positive breast cancer, on the other hand, expresses a receptor called the HER2 receptor. It overexpresses it on the cancer cell. So here you can see, again, in a very simplistic diagram, that HER2 protein, or that HER2 receptor, is overexpressed on a breast cancer cell compared to that normal cell. And when we're talking about triple negative breast cancer, the reason it's called triple negative is because it is negative for all three of those receptors. It's negative for estrogen receptor, progesterone receptor, and the HER2 receptor. And oftentimes you'll get a pathology report and you're given information about the breast cancer grade. And so ultimately, this is a pathologist reviewing very systematically under a slide how aggressive this cancer looks. So there's a normal breast cancer, a normal breast cell on that far left side. And as we progress and see, the worse, the higher the grade, the fewer characteristics that are retained of the normal breast cancer, of the normal breast cell. And so when we think about well-behaving or less aggressive cancers, we're thinking about that grade 1. It's maintained a lot of the features of a normal breast cell. But as it gets less and less, as the cancer looks less and less like the normal breast cell, then we say it appears to be more aggressive. It appears to be poorly differentiated, or grade 3. And so kind of going through each of these major categories of early stage breast cancer, let's start with the estrogen receptor positive and the progesterone receptor positive breast cancers. And again, as a reminder, these are the breast cancers that express that estrogen receptor and that progesterone receptor using the body's estrogen and progesterone as a food supply. So about 70 to 80% of breast cancers are in fact hormone receptor positive. And so I'll be spending about 70% of the talk talking about hormone receptor positive breast cancers. These types of breast cancers can actually be treated with hormone blocking therapies or endocrine therapy. And these therapies often slow down or stop the growth of hormone receptor positive tumors by preventing the cancer cells from getting the hormones they need to grow. And there's really two kind of major categories of endocrine therapy that we use. So there's a drug called tamoxifen, which is a selective estrogen receptor modulator. And the way this works is that it actually blocks the effect of estrogen, or it blocks the receptor, and it doesn't allow the receptor to get to the estrogen and the progesterone. Then there's a class of drugs called aromatase inhibitors. And what aromatase inhibitors do is actually block the production of the estrogen and progesterone. So tamoxifen is blocking the receptor, and the estrogen and the aromatase inhibitor is actually blocking the production of the estrogen and progesterone. And so how do we choose who we give what drug to and why? And so we really, when we're thinking about hormones, we actually, it makes sense. We have to think about whether someone is premenopausal or postmenopausal, because the source of hormones is going to be, the source of estrogen and progesterone is going to be very different between your premenopausal patient and your postmenopausal patient. Premenopausal patients will have their hormones primarily coming from the ovaries. The estrogen and progesterone are going to be the primary producers of the hormones. And postmenopausal women no longer are getting their estrogen and progesterone from the ovaries. And so they're getting their hormones from peripheral tissues, adrenal glands, fat cells, muscle cells, etc. So for premenopausal women, when we're thinking about endocrine therapy or those hormone blocking therapies, they can get either tamoxifen plus minus ovarian suppression, or an aromatase inhibitor plus ovarian suppression. And postmenopausal women, you can really do either one. We prefer to do aromatase inhibitors in postmenopausal women because there's data that has shown that these work better in postmenopausal women. And I do want to just stress that aromatase inhibitors are not effective without ovarian suppression in premenopausal women. And so when we're thinking about ovarian suppression, that's essentially giving a medication to suppress ovarian function. And we can do that with a medication called gaserelin or Zoladex, Leuprolide or Lupron. And essentially the big side effects are going to be menopause symptoms, things like hot flashes, vaginal dryness, joint pain, loss of bone density. These are often monthly injections. Sometimes we can get away with doing injections every 3 months. And then we're often following blood work to make sure that the ovarian function is nice and suppressed, to make sure that we're getting effective therapy from the treatment that they are on. And so you may have noticed that I mentioned, tamoxifen or aromatase inhibitors for premenopausal women. If we do aromatase inhibitors, why do we would need to we would need to suppress ovarian function. Well, why do we suppress ovarian function in certain premenopausal women? There's several large studies that have been done that have shown that there is a role and that there is a benefit to doing ovarian function suppression for women who are premenopausal with who have had breast cancer. So there's one particular trial, the SOFT trial, or the suppression of ovarian function trial. Over 3,000 premenopausal women were enrolled, and they were randomized to receive tamoxifen alone, ovarian suppression plus tamoxifen, or ovarian suppression plus exemestane. And what was found at 8 years disease-free survival or freedom from distant recurrence in those who had received chemotherapy was that the patients who received ovarian suppression plus endocrine therapy did better than those who received tamoxifen alone. And so this was further confirmed by soft text trial. There's, like I said, multiple trials out there that have assessed this. Patients are randomized again to receive tamoxifen plus ovarian function suppression versus exemestane plus ovarian function suppression. And again, we're seeing that there is a difference, and that difference was actually most pronounced in those who had received chemotherapy previously. And again, overall survival, so in the group that did not receive chemotherapy, there was not a huge difference there was actually no significant, statistically significant difference in how long people lived. But in those who had cancers that were high enough risk that they needed chemotherapy, there was a difference in how long they lived if they were able to get the ovarian function suppression. And so how do we put all of this together? Well, when we're thinking about patients who have hormone receptor positive, so estrogen or progesterone receptor positive breast cancer, those who are low risk, right? Thinking about small tumors, lymph node negative, highly estrogen receptor positive, and low oncotype. I'll talk about what oncotype is in a second, but low oncotype score, then you can really move forward with endocrine therapy or hormone blocking therapy right away. And if they're premenopausal, you can go to tamoxifen. If they're postmenopausal, you do an aromatase inhibitor. Those women who are high risk, so large tumors, lymph node positive tumors, high oncotypes, they're the ones who typically will need chemotherapy. The type of chemotherapy will be driven by the oncologist. And ultimately, when you're thinking about endocrine therapy for premenopausal women, that is where we suppress ovarian function, give an aromatase inhibitor, and then in postmenopausal women, it's the same thing. You stick with the aromatase inhibitor. So with hormone receptor positive breast cancer, we can sometimes omit chemotherapy, as I alluded to in the last slide. And so there's a test called the Oncotype DX, where the patient's tumor is sent to a company called Genomic Health, and that company assesses the expression of 21 cancer-related genes in the patient's tumor, and they have their algorithm, and it results in a recurrence score where they're a recurrence score that is on a scale of 0 to 100. And this score is actually associated with risk of relapse. And oftentimes, this is what the report looks like. Please take note that this is for node-negative patients. So this, again, the Oncotype DX is a 21-gene recurrence score. It's a reverse transcriptase PCR-based gene expression profiling assay, includes 16 cancer genes and 5 reference genes. And ultimately, that recurrence score actually helps us make decisions as to whether or not there would be a role or a benefit to giving chemotherapy in women who have, or in people who have hormone receptor positive breast cancer. So how do we determine who gets chemotherapy and who can we omit chemotherapy for? And so again, menopause status matters. Age matters in these cases. So we'll start with postmenopausal because that's sort of the most straightforward. Women who are postmenopausal, really over 50 years old, they're considered high risk if they have a recurrence score of 26 or higher. And if we see that recurrence score of 26 or higher, we recommend chemotherapy. Of course, taking into account the person and the patient, but we would think about chemotherapy in that case. And we know there's a benefit to chemotherapy. Low risk would be 25 or lower. And again, postmenopausal women, patients, low risk of recurrence with endocrine therapy alone. And really, there's no role for giving chemotherapy in that setting. Premenopausal patients, it gets a little bit more complicated. Again, high risk, very clear cut, recurrence score 26 or higher. There is a benefit to giving chemotherapy. Low risk, 10 or lower, right? There's really no benefit to giving chemotherapy, endocrine therapy alone would be enough. There's then this intermediate risk, right, where it's like the 11 to 25 range. What do we do with that setting? And so in that setting, and so there was a large study called the Taylor-X study that actually asked this question, and patients were randomized. Here you can see, if you look kind of straight down the middle, randomized to receive, if they had a recurrence score of 11 to 25, they were randomized to receive endocrine therapy alone or chemotherapy plus endocrine therapy. And here are the results of that study. So invasive disease-free survival for that intermediate risk group, we see that there's actually, so we see that those curves are essentially right on top of each other. Those who got endocrine therapy versus those who got chemo plus endocrine therapy, that looks like they did about the same. Sounds pretty straightforward, right? But unfortunately, it's not so straightforward. So when they did an exploratory analysis for age, what was found was in those who were 50 years or younger, well, if their score was 11 to 15, there was really no difference in distant recurrences. Scores of 16 to 20, well, slight difference, again, not a huge difference, but it's that score of 21 to 25 where we're seeing much, a 7% decrease in distant recurrence if patients received chemotherapy. And so it ultimately does end up being a discussion. It is a very personal, it ends up being a shared decision between the patient and their doctor as to whether or not, 7% is a high enough number for that person as far as risk of recurrence goes. And so it ends up being very much a conversation. So you may have noticed that I was really focused on node negative, so patients who do not have lymph nodes involved. Well, what about those who have lymph nodes involved? What is the role of chemotherapy there? And so we know if there's more than 4 lymph nodes involved, there is a benefit to giving chemotherapy, and that would be something that would be considered. However, what about that 1 to 3 lymph node range? Well, there is a study called RxPonder that asked that question. Can we use the Oncotype DX here to determine whether or not there's a benefit to giving chemotherapy? So again, women, actually this was key entry criteria for this study: women age greater than or equal to 18 years, estrogen and progesterone had to be, receptor status had to be positive, and they had to have 1 to 3 lymph nodes involved. And so if they had a recurrence score greater than 25, again, very straightforward, there's a benefit to chemo. But if they were in that 0 to 25 range, they were randomized to get chemotherapy followed by endocrine therapy versus endocrine therapy alone. And here we see in all participants, maybe there was a slight difference, but not, again, statistically significant. They broke it down and looked at postmenopausal patients. So on the right, we're looking at postmenopausal patients, and there was really no difference in how well patients did if they had endocrine therapy alone versus chemotherapy plus endocrine therapy. So chemotherapy really didn't add did not significantly change the probability of invasive disease-free survival, or it did not reduce that risk of preventing breast cancer recurrence in postmenopausal patients. However, if we look at premenopausal women or premenopausal participants of this study, there was a difference. And so those who did get chemotherapy plus endocrine therapy did actually better. They had fewer recurrences. And so in this study, what was found was that patients who have lymph node positive disease and are premenopausal should get chemotherapy. And finally, one of the last trials that I'll talk about for hormone receptor positive breast cancer is the Monarch E trial. So you may remember kind of that slide I showed where we delineate high risk, low risk patients, and the high risk patients got chemotherapy followed by endocrine therapy. Well, this study was looking at the role of adding something to that endocrine therapy. So adding something like adding the drug abemaciclib to endocrine therapy. So abemaciclib is a CDK4/6 inhibitor. We use it in the stage 4 setting all the time, and it is actually standard of care as part of stage 4 hormone receptor positive breast cancer. So this study actually was looking at moving this drug to the earlier stage setting to see if we can reduce the risk of breast cancer recurrence. And so in patients who had high risk disease, high risk early stage breast cancer, that's hormone receptor positive. And what they defined high risk as, and if you look on the left in the purple box, greater than 4 positive nodes, or if they had 1 to 3 positive nodes and at least a tumor in at least one of the following: a tumor that was greater than 5 centimeters, a tumor that had a grade that was grade 3. And so remember, grade was defined by the pathologist and how aggressive the tumor looks. And then something called Ki-67 being greater than 20%. Ki-67 is a proliferative index that, again, is denoted on the pathology report by the pathologist. And those patients were randomized to get their standard endocrine therapy, so tamoxifen or an aromatase inhibitor. I believe in this study they used aromatase inhibitors, and then versus randomized to receive the standard endocrine therapy plus abemaciclib. And what was found was that those who received abemaciclib plus endocrine therapy did better than those who received endocrine therapy alone. There were fewer distant recurrences. There were fewer recurrences of the breast cancer in distant sites. Fewer recurrences in the bone, the liver, the lungs, other parts of the body, which is great. So now this has become standard of care for women who have hormone receptor positive breast cancer that is considered high risk. So that was a lot of information about estrogen receptor positive, progesterone receptor positive breast cancer, and really, sort of a global overview of how we think about things when it comes to early stage hormone receptor positive breast cancer. Let's talk a little bit about another type of breast cancer called HER2 positive breast cancer. And so HER2 positive breast cancer is a breast cancer that tests positive for a protein called human epidermal growth factor receptor 2. And here I sort of bolded where that HER2 comes from. And this protein actually promotes the growth of cancer cells, and it's found in this overexpression of HER2 is found on about 10 to 20% of breast cancers. And again, pulling that original slide back up as a reminder, HER2 positive breast cancer, we have overexpression of that HER2 protein. But there are lots of treatments that specifically target HER2, and these are treatments that are extremely effective. In fact, these treatments are so effective that the prognosis for HER2-positive breast cancer is actually quite good. So I'm going to just review two key trials that have play a major role in how we make decisions regarding treatment. So this first trial, I'm just showing sort of the layout of the trial, but it was called the Catherine trial. And they accrued over 1,400 participants to the study. All of these patients had HER2-positive breast cancer. They had completed preoperative chemotherapy plus targeted therapy, so targeted therapy being trastuzumab. And at the time of surgery, so the surgeon removes the tumor after this patient, these participants had upfront treatment, so upfront chemo plus targeted therapy, they go to surgery, and the surgeon removes the tumor, and then that tumor that's removed is then reviewed by the pathologist, and that pathologist looks to see what kind of response did this person have to the treatment that they were given before surgery. And if they have what we call what is a perfect response, so complete resolution of invasive cancer, then we call that a pathologic complete response. If there was, some response maybe, right, but maybe not a perfect response, there were still some invasive cancer cells in the specimen that was removed from the breast, then we call that residual disease. So in this study, those who had residual invasive cancer after surgery, or at the time of surgery, were then randomized to receive continuation of trastuzumab versus switching to a different targeted therapy called TDM1. And I don't believe I didn't include a slide about the results of this, but it ultimately showed a significant difference in recurrence of disease, and that has now become standard of care. So in patients who have larger tumors greater than 2 centimeters, or tumors that are lymph node positive, we choose to give them we recommend giving chemotherapy plus targeted therapy up front to then get a sense of what their response to treatment looks like. And then we are able to tailor their treatment after surgery based off of what their response to treatment before surgery was. And ultimately, not everyone needs to have treatment. Not everyone with HER2-positive breast cancer needs to have treatment before surgery. And so there is a select group there are certain patients who may be able to get away with doing surgery up front, followed by a more abbreviated chemo. And those are the patients who have sort of what we call low-risk disease, lymph node negative, smaller tumors. And so they can go to surgery up front, and they can get 12 weeks of chemo, plus the trastuzumab, which is a targeted therapy, and then that would be followed by completing a year of the trastuzumab alone. So it tends to be a little bit more of a optimization of their cancer treatment, and it tends to be just a bit better tolerated. But again, these have to be those patients who have lower risk disease. And finally, let's talk a little bit about triple-negative breast cancer. So triple-negative breast cancer, as I'd mentioned previously, lacks the expression of estrogen, the estrogen receptor, the progesterone receptor, and the HER2 receptor. It accounts for about 15% of breast cancer, and it disproportionately affects younger patients. Patients less than 40 are more likely to have triple-negative breast cancer. It's actually much more common in Black persons than persons of any other race or ethnic group. And it's actually often associated with what we call visceral metastases. So spread of the cancer to organs like the liver, the lungs, the brain, for example. And so, so recurrence of triple negative breast cancer actually happens earlier than kind of the non-triple negative breast cancer. It tends to be on a more aggressive side. So if it's going to come back, we tend to see it come back sooner than we see other types of breast cancer recurring. And as I mentioned, when we do see recurrence of triple negative breast cancer, it tends to be more likely compared to non-triple negative breast cancer, it tends to much more likely present with visceral disease, so disease in the liver, the lungs, the brain, over things like the bones. So if you look at this image, you'll see that in triple negative breast cancer, the presentation of distant disease in the bones was 10%, but for non-triple negative breast cancer, it was 40%. Whereas for every other part of the, for kind of other parts of the body, we're seeing it much more likely to be triple negative breast cancer. And so just a few key landmark trials for the treatment of triple negative breast cancer. In the past, we've really had to focus on giving chemotherapy for these patients, and chemotherapy still remains the backbone of treatment for these patients. There aren't really, again, those same targets don't exist, and where there's studies that are ongoing looking at the potential for different targets, but really without the estrogen, progesterone, or HER2 receptor, right now we don't have a great target. So we are often left with chemotherapy only to treat triple negative breast cancer. However, there is, for early stage breast cancer, I should add. So there was a trial called the Keynote 522 trial that looked at adding pembrolizumab for early triple negative breast cancer. Pembrolizumab is an immunotherapy drug. And what was found, so patients were randomized to receive either a pretty extensive chemotherapy regimen or that same extensive chemotherapy regimen plus pembrolizumab, and before surgery, and then they went to surgery, and then the group that was getting the pembrolizumab or the immunotherapy continued it after surgery. And what was found was that those who got pembrolizumab in combination with chemotherapy actually did better than those who did not get the pembrolizumab or the immunotherapy. And so ultimately, this study enrolled over 1,100 patients. The group that got pembrolizumab, the immunotherapy plus chemotherapy, had a higher rate of a pathologic complete response compared to the group that got chemotherapy alone. They had fewer events happen, so fewer events of distant disease, death, than the chemotherapy alone group. And anytime we're adding treatment to a regimen, so we're adding a drug, in this case, pembrolizumab, we always want to make sure that it's also reasonably tolerated, right? And so the number of adverse events between the two groups was about similar. And so that was actually really great to see. And again, how someone does with the chemotherapy or immunotherapy or combination chemo immunotherapy before surgery, then often will tailor what we give them after surgery. And so this study, the CREATE-X trial, added 6 months of a drug called capecitabine after completion of chemotherapy, preoperative chemotherapy or neoadjuvant chemotherapy for tumors who then did not achieve that pathologic complete response. And what we see was, well, there was actually a benefit to giving capecitabine to all comers, everyone enrolled in the study, and this study enrolled anyone who was hormone receptor positive or triple negative. However, when they broke it down, it was actually those who had triple negative breast cancer that had the most benefit, and was probably actually driving that difference in the curve of all comers in the study. And so now, based off of this CREATE-X trial, we recommend capecitabine, 6 months of capecitabine, an oral chemotherapy drug, for those who have residual disease following treatment of triple negative breast cancer, following surgery for, just to clarify, following surgery after neoadjuvant chemotherapy or preoperative chemotherapy for triple negative breast cancer. I do want to kind of add this slide about clinical trials. I think it's incredibly important to ask about clinical trials. There are constantly new treatments, new regimens, new combinations of drugs that are being made available to patients. And so I think it's incredibly important for the patients in the audience to ask your provider about clinical trials, and then if you're a provider, to know about the clinical trials in the area, to then, again, there's never any obligation to enroll in a clinical trial, but it's important to know what options are out there and if it's anything that you may be interested in. Another major facet of the treatment of breast cancer is mental health. I think that it's something that's often overlooked, unfortunately. It is tough to go through the treatment of breast cancer, between all the appointments, between the surgery, the chemo, the radiation, all of the appointments, and then being on treatment for, up to potentially 10 years afterwards. And it can take its toll. And I really want to discuss this because it is actually it is something that is highly prevalent. Prevalence of anxiety and depression reported up to 77% in patients who have had breast cancer. Year 1 up to 50%. There was another study actually that mentioned in the first year after breast cancer, about half of patients have experienced anxiety or depressive symptoms. Years, kind of that second to fourth year, about up to 25%. Year 5, about 15%. I mean, these are not small numbers, especially when we think about the fact that breast cancer is the most common type of cancer in women in this country. And so I want to urge providers in the audience, patients in the audience, family members, to be aware of this and to be proactive and ask about it. So for mild and moderate depressive symptoms, there are strategies that can be helpful. This is from breastcancer.org, setting realistic goals, breaking larger tasks into smaller ones, not expecting to be back at work and full-time, a week after surgery, but again, setting those realistic goals, trying to spend time with people. And I know COVID has made that even harder, but people that you were previously spending time with, it's very easy to alienate, yourself or as you're going through treatment. But it's important to recognize that we don't, as someone who treats breast cancer, I do not want this to ever be something that defines you or who you are. And I always hope for my patients to get back to, whatever the new normal is for them. And so finding someone you can talk to and confide in. It doesn't have to be family. It doesn't have to be a friend. It can be a professional. And there are support services out there. Doing activities that you find naturally relaxing and things that you did before breast cancer that you found relaxing, hiking, biking, etc., anything. Being physically active every day. And I will say, I know that's incredibly hard. And I think being physically active every day is a really tough request. But even like a few days a week, I think it can make a huge difference. reaching out, I think the key takeaways though, reaching out, talking to your doctor about the fact that it is tough and that you are experiencing these symptoms is incredibly important. And recognizing that you're not the only one going through this, right? This is very common, and it is something we see quite frequently with people who have undergone treatment for breast cancer. And so today I really hope that I was able to give you an overview of early stage breast cancer. I really hope that you were able to gain some insight about the radiology reports and staging. And we reviewed just the tip of the iceberg of key trials that impact our decisions. And so I would love to answer any questions that you might have.
Thank you very much, Dr. Riaz, for your presentation. It was very informative and insightful. We are going to go ahead and move into our Q&A section of this presentation. We did have several questions, and some of them were about people's personal circumstances. Just because of time constraints, I'm going to try to just focus in on some general questions.
Sure.
But if you want to explore the personal questions, you're welcome to contact us at Bay Area Cancer Connections, and we can connect you with one of our cancer information and education specialists.
Absolutely.
Yeah. So let me start with this one. Can cancer pathology change if I had estrogen receptor positive, progesterone receptor positive, and HER2 negative? If I were ever to get a recurrence, would it be the same pathology, or could it change or become triple negative?
That's an excellent question. Anytime there is a concern for recurrent disease, we would of course scan you. We would look for any sign of recurrent disease in that particular case. If we find recurrent disease, we always recommend biopsying, right? Not only to confirm that this is in fact breast cancer, but to whoever asked this question's point, cancer can evolve, things can change. And yes, there can be a discordance between the original diagnosis, the original receptors, and the receptors of the recurrent disease. And so we always recommend rebiopsying, retesting any recurrence to ensure that there is no discordance, and that your doctor then knows, or your provider then knows, what they are treating. To give a number, I believe there's some studies that report about 36 to 40% incidence of discordance between the original pathology and recurrence.
Okay, another question we have. What does the latest research show about the use of estrogen alone without progesterone?
Use of estrogen, and I guess just to clarify, use of estrogen.
Another one.
Sure.
For Oncotype scores, you show premenopausal women in 3 risk categories and postmenopausal women in 2 categories. Why is this?
So if you remember, there was the Taylor X study that actually delineated those who were premenopausal versus those who were postmenopausal. And those who were postmenopausal, there was that same intermediate risk score, but what was seen with postmenopausal women or patients, participants of that study, was that there was no benefit to adding chemotherapy to endocrine therapy. Whereas if we looked at the participants who were less than 50 and or premenopausal, there was a benefit to adding, or there was a potential benefit of adding chemotherapy if they had that intermediate risk score. So the numbers are the same, but whether they're low risk, intermediate risk, or high risk changes based off of whether they're pre or post menopausal. Does that make sense? And I wish I don't know if I could pull that slide back up, but ultimately the scoring is the same, but the classification of the score changes between pre and post menopausal.
Thank you.
Yeah.
Thank you. Let's see. So we had a question. Someone was talking about having dense breasts and triple negative breast cancer. And they're worried about the effectiveness of MRIs and mammograms and ultrasound. They're asking, what are the best strategies for detection? What are like the best strategies?
That's a very good question. So mammogram should absolutely be a part of the surveillance, right? But surveillance is more than just the imaging. They should be seen by their oncologist at least once every 6 months. During those 6-month visits, they should get a breast exam. They're going to be asked a whole lot of questions about symptoms. And I always tell my patients there's 3 P's of symptoms that I'm looking for. Anything that is persistent, so anything that doesn't feel normal, that isn't, or a new pain or a new ache that isn't going away. Anything that is progressive, right? So it's not only not going away, but it's also getting worse, or it's perplexing. So we don't have a good reason, right? You weren't just, painting your walls and now you're having some shoulder soreness, but there's no good explanation for it. So again, every 6 months, clinical breast exam by your oncologist. And again, going through and understanding if there's, any new symptoms that are concerning. As far as imaging goes, I mentioned surveillance mammograms are incredibly important. Depending on your particular risk, that takes into account genetics, family history. Density of breasts is also an important facet, right? If they were able to see the tumor on a mammogram previously versus whether they weren't, you may need an MRI. There is also now screening ultrasounds, and the role of screening ultrasounds is very, it's not clear yet. They're very new. We do offer them at Stanford, and what I usually do for my patients who have denser breast tissue is, with the mammogram, I will order a screening ultrasound to just give us that additional information, that additional peace of mind with regards to surveilling the breast tissue.
All right. Well, thank you very much. I believe we are right on time, so that was our last question. But thank you, Dr. Riaz, for presenting, and thank you everyone for attending this presentation. After about a 10-minute break, we are going to have the Living Well with Cancer presentation with Dr. Kate Beebe-DeVarney. All right. Thank you, everyone.
Thank you. Bye-bye.
Bye.